I started it.
Okay. And would you also like to tell why you have chosen this article, or how you have chosen this article, how you have selected this article?
Basically, we wanted to this article as we went through, we wanted to discuss network meta-analysis in details because this is an important topic and it is difficult for all of us. One minute. Mute everyone. So basically, this is very important topic as a network meta-analysis for us to understand. And in order to understand that, we have taken this article as in order to understand the graphs, the charts which are there in the network meta-analysis. To get an easier and to get a clearer idea, we have used this article. This is a network meta-analysis, but it is not a very robust study, if I in order to say that, because there are certain lacunae. But we had previously very important topics have already been discussed, so we have taken this article just to understand the network meta-analysis, the graphs, and to have an idea about the probiotics as well. But this study cannot be generalized because there are certain issues with it. We will get to know what are those as we go on in the subsequent slides. So where we so what is the role of probiotics as a proposed mechanism? The one thing important is that it is important in maintaining a proper gut barrier. Second important thing is it helps in the competitive inhibition of the pathogenic bacteria against the commensal bacteria. So that is why it is very important for us. As you can see by the laser point in the diagram, these are the pathogenic bacteria which are getting a competition from the commensal bacteria. And that is provided by the probiotics. And the third important thing is that it helps in getting a good secretory IgA that helps in preventing the sepsis and NEC. Now we know, as per the theory is concerned, let's come to the evidence. As evidence, the first systematic review was done in 2007 by Dr. Sanjay Patole and his team, who has done a tremendous work in the probiotics and in the neonatal gastroenterology. So what was this study was, the study had various randomized controlled trials, and it was put up in a forest plot, and a systematic review and meta-analysis was done, which found that there was a significant reduction in the necrotizing enterocolitis stage 2 and above, where the relative risk had reduced to 0.36 with a good confidence interval. Subsequently, in the year 2010, another study by the same team had come up, where they had updated the previous meta-analysis by using the three new randomized controlled trials, that is Lynn, Samantha, and the Rube. And after that, what they found out was there was a statistically significant difference in reducing the necrotizing enterocolitis by using the probiotics. Now, next after this, in 2015, the Cochrane came up into the picture, and Cochrane presented the article where they had done a systematic review, where they found out that based upon all the previous randomized controlled trials, again the result came in the favor of the treatment of probiotics in order to prevention by probiotics in order to prevent a necrotizing enterocolitis. So till now we had the evidence that necrotizing enterocolitis to prevent, probiotics is the answer. In 2017, another study came up by the same team, and what they did was they tried an animal models about the use of probiotics, and what they found out was there was definitely a significant reduction in the NEC. Now, since there is a reduction in NEC, then why is the need for the further research? Because the previous studies, what they have not done is they have not tried to find out about the feeding, because type of the feeding is a very important potential confounding factor, because it has a synergistic effect with the probiotics. The human milk oligosaccharides, they help in increasing the efficacy of the probiotics. So that is why we need to include in our studies the percentage of the mother's own milk, how much was the pasteurized donor human milk, how was the fortification done, what was the duration of exclusive mother's own milk, because these are all very important potential confounding factors which actually change the end result. That is why we need to know. And the second important thing is the strain specificity. How is the different strains acting at the different level in the gut? And every strain has a different way. Every probiotic has a different way of preventing NEC. So we need to specify which strain has how much efficacy. For that, the network meta-analysis came in 2018, which tried to find out which strain is best among the various strains which people have been using. But there also they forgot, or they had a drawback, that they did not include the type of feeding as an effect modifier. That is why the results were good, but still they do not hold good, although their results have been used to establish the SVGAN's guideline. So this was the network meta-analysis. We will get familiar to this network in the subsequent slides. But what was important was bifidobacterium lactis, lactobacillus reuteri, and many other probiotics were shown to have a good improvement in terms of efficacy in preventing NEC. But there were issues with this study. One was that type of feeding, and second thing was there were certain confounding factors like lactoferrin, which was used, which can also have an effect in preventing late onset sepsis. They were preventing necrotizing enterocolitis. So that is why they had certain issues, for because of which the new study came in 2021, which was published in the nutrient article, which we are going to discuss today. So aim and object of this study was, first is the role of probiotics in preventing NEC and to identify the strain with the maximum efficacy. And second thing, which was not there in the previous trials, was to find out the potential of the feeding as an imminent effect modifier. So these were the main two aims of the study, and subsequent results we will know what happened to these two aims. So the study was conducted as a network meta-analysis using the systematic review of the various randomized controlled trials which had been done till now, where NEC was used and premature babies were studied. And probiotics nomenclature was considered as an essential criteria. The search source was the PubMed and the Cochrane, and that was done up till 7th of January 2020. The missing details and the type of feeding were requested by contacting the authors. Now, the statistical analysis was done by the random effect Bayesian network meta-analysis. Now, this term might be confusing. What is random effect? What is Bayesian? We are familiar with the network meta-analysis, and we will be revising the entire network meta-analysis. Plus, we will know what is random effect and what is Bayesian word means. So the random effect basically means that is there any intention to generalize the results beyond the included study? Basically, if the author has an intention to generalize the result, then the answer is yes. If not, then the answer, if not, then if the answer to this question is yes, then the random effect model is used. If no, then the fixed effect model is used. Basically, these two are basically two types of statistical models. And the second thing is, if you have a larger number of the studies, then you can use a random effect model. But you have a smaller number of studies, then use the fixed effect model. And third important thing is the heterogeneity or the homogeneity. If you have a good homogeneity between the various studies, then you can use a fixed effect model. But if you have heterogeneity between the various studies, there is a differences that can affect the final result, then you should use a random effect model. So basically, these are two types of statistical model. And second thing is Bayesian. Now, what does the Bayesian means? Basically, it is a way of assessing the probability, which helps us in assessing the indirect evidence. Now, there are two types of probabilities, that is Bayesian approach and frequentist approach. Bayesian approach is basically based upon the prior information. If you have prior information about the certain thing for any study which you are doing, and you have the current data, so using your prior information and the current data, if you get the probability, then that is called as a Bayesian approach. In the frequentist approach, there is no previous prior information. In simple words, in a day-to-day life, for example, in order to understand Bayesian approach, suppose a new resident has joined, and as a consultant, suppose you are a consultant, new person has joined, and you do not know any background about that resident, and how does that resident works will be a probability using the frequentist approach. But if suppose you had a background, that resident is good, that resident had done his undergraduate from All India Institute of Medical Science, so there is a probability, there is a prior information that resident might be good. You have a preconceived notion, you can say, that the resident might be good. So that information is basically the Bayesian approach in assessing the probability. Still, these are very confusing. I have tried to explain, but they need an expert statistician in order to get the network meta-analysis done. From a clinician point of view, we should at least know what is random effect and fixed effect, and what is Bayesian and frequentist. At least we should be familiar with the terms. Now, coming to the network meta-analysis. So the network meta-analysis, basically, as a hierarchy, we all know that from randomized control trials goes to systematic review, goes to meta-analysis. Difference between meta-analysis and network meta-analysis is that the meta-analysis can compare only two interventions at a time, and it can evaluate only head-to-head trials. But what is network meta-analysis? Why it is different? Because suppose there is a drug A and suppose there's a drug B, and we have the various randomized controlled trials and systematic reviews where we have a direct evidence between the drug A versus the placebo and the drug B versus the placebo. But by a meta-analysis, we cannot find out what the A has to do with the B. That means how can we compare A and B? So for that, the network meta-analysis come into the role, where they can find out an indirect evidence based upon the previous direct evidences against the placebo to find out between drug A and drug B which one is better. And the combination of these two, direct and the indirect evidence, is known as the mixed evidence. So suppose we have done in our undergraduate the anxiety disorder drugs we are familiar. Suppose there is a drug which is paroxetine and second is a sertraline, and they have the studies against the placebo, but there are no actual randomized controlled trials done between the paroxetine and sertraline. So that becomes an indirect comparison. But if in actual there was studies where the randomized controlled trials were done between paroxetine and sertraline, then it becomes a direct effect. Now, suppose, and we all know that there are various other medications like escitalopram. It has studies against placebo. Fluoxetine has a studies against placebo for anxiety. Pregabalin, venlafaxine. Then you have lorazepam. So we have these many drugs which are there against the placebo. They are randomized controlled trials. So the network meta-analysis will help us in doing a pair-wise analysis between these two drugs, in order between all the two drugs. So one drug can be compared with all the other drugs in order to find out which one is better among the primary outcomes which we have set. And in the market, or in the previous past, there are many other medications which have been done, which have been tested against head-to-head trials also. So you have a mixed type of evidence. You have a direct evidence also, and you have an indirect evidence also. And when you put together all this in the network meta-analysis, you generate a network diagram where you have the direct evidences as well as the indirect evidence. The direct evidences are head-to-head control trials and the placebo control trials between all these drugs. And when I put these drugs and tried to find out the indirect evidence using the statistical methods, I'll be able to compare each and every drug against their other drugs. For example, I can compare escitalopram against the placebo and all these other six drugs in order to prevent the anxiety. So that is the benefit. In a single study, I'm able to study multiple, I'm able to do multiple studies. In a single study, I'm able to find out the difference between the various drugs. And on that basis, I can even rank which drug is better and which drug is not better. Well, that will come in the subsequent slide. So this is how the actual network diagram looks like. The previous was just for your understanding. So here there are various things to understand. The first thing, as you can see by my laser pointer, that this is a node, and there are various other nodes you can see, and these nodes are color coded based upon the class of the drug, and these are called as the edge. Now the size of the node denotes the total number of participants that have been studied. For example, in this network diagram, the maximum number of the participants which have been tested for the efficacy of timolol in primary open angle glaucoma, timolol has the maximum number of participants. That is why the size of the node is maximum. And the thickness of the edge denotes the total number of randomized controlled trials done between the two drugs, like timolol and latanoprost. The thicker the edge, the larger number of randomized controlled trials have been done. And the last is, in few studies, these edges are also color coded based upon the risk of the bias. Now, this is the table. Just to show you, from this table we generate this network diagram. Now, this network diagram is the heart of the network analysis, and the three pillars of the network analysis are heterogeneity, transitivity, and consistency. Now, heterogeneity is all we have studied in the forest plots, and we are very familiar with this term. Basically, the statistical heterogeneity is what we are trying to understand in the network meta-analysis, where the statistical heterogeneity is basically the variation between the various variability in the intervention effects that defines the result. So if the variability is too much that affects the result beyond the expected variation, then it is called as the statistical heterogeneity. And so I'll not go into that because we know that how the heterogeneity looks like, and we have been familiar with the term. But what is important is the transitivity and the consistency. Now, the transitivity is basically means that, in simple terms, when we are comparing the two comparative groups, that is two different drugs, in terms of the potential effect modifiers. What is potential effect modifiers? Basically, these are the characteristics that have an impact on the intervention. So when we are comparing drug A versus placebo, that is a one group, and drug B versus placebo, that is one other group, and these two interventions we are comparing against the potential effect modifiers, then if there is the presence of an effect modifier, that can definitely affect the result. then that is a breach in transitivity. So basically, transitivity means that how is the two comparative groups equal to each other in terms of effect modifiers. For example, in open angle glaucoma, as we know that this is a disease which is age related. So suppose if in one group, for example, timolol versus latanoprose, the study has been done in younger age group, and whereas all the other drug comparisons have been done in older age group, so then we cannot use the network meta-analysis, because here the age becomes the biggest effect modifier and there's a breach in the transitivity. So that's why the comparative group should be same, in order to, they should be having a transitivity in order to do the meta-analysis. And the next important thing is the consistency. Now what does consistency actually mean? So we know that from now that drug A versus placebo is a direct evidence, drug B versus placebo is a indirect evidence, and we do not have any randomized controlled trials for that matter between drug and drug B, and based upon the network analysis we get an odds ratio. So we get a probability which drug is better than drug A or drug B. So, but in suppose if there was randomized controlled trials actually between drug and drug B, and if that result matches the result of the network meta-analysis, then the consistency is achieved. But if not, then there is the consistency is breached. So that is why transitivity and consistency are the two important pillars. Now coming to how do we present the network meta-analysis, basically based upon the league table and the Sucre score, that is ranking probability. Now what is the league table? Basically league table is a way where in a step ladder fashion we arrange all the medications which have been used. For example, in open angle glaucoma we have arranged all the medications which have been tested in the network meta-analysis, and each drug pairwise have been compared with the other drug, and the results are shown in these rows and in these columns. Now suppose just concentrate on the highlighted one, that is bimatoprost versus placebo. So here we can see that the result is in minus 5.61. That means that bimatoprost reduces the open angle glaucoma versus placebo. And similarly, you can see the various other drugs against each and every drug. Here in the rows, suppose if the result of the two drugs, if it is in less than 0, that favors the row, that is the bimatoprost. But if the result was in more than 0, then it would have favored the column. So this is how the various drugs pairwise analysis of each and every drug with the others have been shown in this league table. Now this is very important. And lastly, can you see the bimatoprost line? Just I have encircled all the results are in the negative. That means that this drug is most superior among all the other drugs in reducing the open angle glaucoma. Therefore, we can compare these two drugs and we can even rank these drugs based upon the probability, which is basically done by a surface area. We do a cumulative probability areas where we find out the amount of the area. The amount of the area under the curve is directly proportional to the ranking of the drug. So here you can see that bimatoprost, as we had seen that this drug was superior to all the other drugs in open angle glaucoma. And can you figure out that the area under the curve is a maximum versus the placebo? Placebo, the area is 0. So thereby, based upon this, we can arrange in serial order the various drugs which are used for the open angle glaucoma. And thereby we can produce a rankogram where we can say that which drug has the maximum probability of being at the being the rank 1. So basically here what does 953.953 means, that this drug has a 95% probability of being the best, and this has been color coded as well. The dark red color means that there is 95% probability, because majority of the bar is in terms of dark red color. So that means that there is 95% probability that this drug is the best drug amongst the various other drugs that have been studied in the network analysis for reducing the open angle glaucoma. On the other hand, the blue has been ranked as rank 15 on your screen. And just look at the placebo. The placebo is filled with the dark blue color. That means this drug has almost 95, almost 100% probability of being ranked as 15. And similarly, all the other drugs have been color coded. The bars are color coded in order to understand that which drug has the maximum probability. The maximum share of the color, like suppose here if it is light yellow, we can see from the card color coded cards that it would be somewhere rank 7 or rank 8. So the maximum amount of the color denotes the maximum rank that drug will deserve in reducing the primary open angle glaucoma. Now there are issues with the sucra's values because they are very low quality evidences. They do not account for the cost and the clinician's familiarity, the drug side effects. That is why, although they give a probability, but this is at the end, it is a probability only to rank these drugs amongst each other. still we need to know the clinical point of view and the cost point of view in order to know which drug is the maximum, has the maximum effect. Now, I hope the network meta-analysis, the basic gist is clear. This will help us in understanding the probiotics for preventing the necrotizing enterocolitis in our network meta-analysis. Now, the statistical analysis, this study basically did the various probiotics were coded by their short forms, and this is the list. You can refer this list later on whenever you are referring this slides back, which will help us you in familiarizing which uh, letter means which probiotic. So these are the list of the probiotics. So the statistical analysis of this study was done using a network diagram. That is the first thing. The second thing is the league table, which we have known. And the third important thing is the relative effect and the credibility interval. When we use a Bayesian network meta-analysis, we do a credibility interval. And when we do frequentist approach, we do a confidence interval. So, and the next important is the forest plots of the various drugs and the sucra. This is how in all these 3, 4 or 5 points, we will discuss the various probiotics in preventing necrotizing enterocolitis. Now, coming to the results of the study. Now, this study was conducted. The Prisma's flow diagram was mentioned in the study, where they had total, after scrutinizing, there were 51 studies. And after finding out the actual studies where they had included the type of feeding, we had restricted ourselves to 30. They had restricted ourselves to 31 studies. So this was the network diagram. I know you now you are familiar. I am quite confident. So we can read this network diagram. Here what we can see that the Mg stands for multigenous, and the LA stands for lactobacillus acidophilus. LR stands for Lactobacillus reuteri, as you can refer back to the chart which I've shown in the previous slides. Here we can see that the placebo is the biggest circle, which means that maximum of the drugs, maximum of the probiotics have been tested against the placebo. And which probiotic has been maximum studied in the past is the multigenous group. That is, the multi-strain probiotics have been studied maximum times versus placebo, and all the others are also studied, but their size denotes the number of the studies. And this with the blue arrow denotes the direct head-to-head trial between the multigenous versus Lactobacillus acidophilus. So this was the network diagram generated. There were 13 treatment criteria, including the multigenous group, and total 42 studies were done, and 9,658 patients were included. And now coming after that, this was the league table of the network meta-analysis. Now, as we had discussed, the drugs are arranged in a step ladder fashion. Here you can see that P means placebo, and this is all the probiotics. And these probiotics have been arranged in terms of the serial order. Now these probiotics, as you can see, that they have been arranged based upon their comparison with each other. For example, Lactobacillus reuteri, when it's compared with the Bifidobacterium lactis, we can extrapolate from the rows and the column, and we found out the result was 1.20. That means that Lactobacillus reuteri has an increased chances of NEC if it is compared against the Bifidobacterium lactis, which says that Bifidobacterium lactis is superior to Lactobacillus reuteri. So in this way, we can compare each and every drug, and we can find out which probiotic is superior to the other, and in a way we can classify them based upon their rank. So irrespective of the feeding type, the first sucra plot that was plotted in this network meta-analysis suggested that Lactobacillus acidophilus is the one which has the maximum probability of being the best probiotic, followed by the Bifidobacterium lactis, which was ranked second, and this was followed by Bifidobacterium longum, which was the rank third based upon the sucra plot. Now, if we see the forest plot was in support of the sucra curve, because sucra curve is the probability. Forest plots are the actual results. So the Lactobacillus acidophilus, Bifidobacterium lactis, Lactobacillus reuteri, and multigenous, all they had showed a good effect, which was favoring the probiotics in preventing the necrotizing enterocolitis stage 2 or higher. But only thing was Bifidobacterium longum, which had the confidence interval or the credibility interval crossing the line of the effect, which is a matter of concern. But what we know that all the other probiotics were definitely helpful in preventing the necrotizing enterocolitis as per the study. This was irrespective of type of the feeding, but we are more interested in knowing, based upon type of the feeding, how does the probiotic efficacy affects. Now, when they did this, when they included all the trials where the type of feeding was mentioned, where they found out that Lactobacillus acidophilus was ranked as the best in the sucra curve. But what was interesting was to note that they did not show a good effect in when the type of feeding was included, as the credibility interval was crossing the line of effect. But if you concentrate yourself to Lactobacillus reuteri, Bifidobacterium lactis, and multigenous group, you were able to say that they had a good effect in preventing necrotizing enterocolitis, as their confidence interval was within the line of the effect, within the left side of the line of effect, thereby proving that they were efficacious in preventing the necrotizing enterocolitis. So there were certain differences in the result when the type of the feeding was included. Further curating about what was the difference, then they included and they studied all the probiotics where actually they were compared between the exclusive human fed and non-exclusive human fed infants. So this network meta-analysis studied these 5 probiotics based upon their comparison between the human milk fed and mixed feeding. So we had Bifidobacterium lactis and Longum, Lactobacillus reuteri, Rhamnosus GG, Saccharomyces, and mixed genus species. Now let us see this interesting sucra plot versus the forest plot. Here you can see the pink color denotes the exclusively human fed infants, and the orange color denotes the mixed feeding, that is the non-exclusively human fed infants. And on your right side, the forest plot, the circle, purple circle denotes the forest plot for exclusive human fed, and the triangle denotes the forest plot for non-exclusive human fed infants. And what you can see here is that in this study, just concentrate the Bifidobacterium lactis, the Lactobacillus acidophilus, the Lactobacillus reuteri, and the mixed genus group. These were the 4 good probiotics that had shown that they had a reduction in preventing the necrotizing enterocolitis stage 2 or higher. And if you compare them with the other drugs also, other probiotics also, they had stood out in preventing necrotizing enterocolitis in exclusively human fed infants. And what we were able to also note that, interestingly, Bifidobacterium lactis was shown to have a good effect in exclusively human fed infants as well as in mixed feeding. But what you can see that in exclusively human fed infant, it was ranked as 1, whereas in non-exclusive, that is in mixed feeding, it was ranked as 5th. And you can see on the forest plot as well, the relative, the odds ratio is 0.04, whereas here odds ratio is 0.32. So odds ratio is very less. That means there is good reduction in necrotizing enterocolitis compared to the non-exclusively fed human infants. So that's why what I'm trying to say here is that there is a reduction in the efficacy between when we test the Bifidobacterium lactis in exclusively fed versus mixed feeding. So that is why the role of the type of the feeding is very important in knowing the efficacy. The efficacy of Bifidobacterium lactis actually has gone down, but still it is, since it is a very good probiotic, it is able to show a good result both in mixed feeding as well as in your exclusively human fed infants. Now, Saccharomyces boulardii was not shown to have any effect, that was ranked 11th and 7th in both. So basically, it is trying to say that this drug, this probiotic was not efficacious in preventing necrotizing enterocolitis. Coming to the mixed genus group, in this mixed genus, we were able to find out that Bifidobacterium bifidium infantis and longum, and another combination, and these 3 combinations in exclusively human fed infants were able to reduce the necrotizing enterocolitis. Now, coming to the mixed feeding, in the mixed feeding, based upon the forest plot, again, Bifidobacterium lactis and Bifidobacterium reuteri, that Lactobacillus reuteri, both were able to show a good effect in preventing necrotizing enterocolitis in non-exclusively human fed. That means that is in mixed feeding infants. And next, as you can see in this figure, they were able to show a good effect in preventing necrotizing enterocolitis. Then the sucra came again. The third sucra that was plotted by the study was based upon the mixed genus probiotics that on exclusively human fed infants. And in exclusively human fed infants, again, what they found out was Lactobacillus rhamnosus, paracrazy. This combination stood out of all the other probiotic combinations. Now, the next thing is interpretation of the results. In exclusively human fed infants, what we were able to find out that Bifidobacterium lactis had a good reduction in the NEC stage 2 or more, and Lactobacillus reuteri also had a good reduction of necrotizing enterocolitis in exclusively human fed infants as well as non-exclusively human fed infants. But what was interesting is that Bifidobacterium lactis had a good relative effect size, was favoring the infants fed with exclusively human fed milk. So that means that if you give human milk and if you test the probiotics, the human probiotics efficacy increases if the infant has been given exclusively breast milk compared to the formula or compared to the mixed feeding. And if we come for the multi-genus products, these three combinations were definitely better than the other combinations. So what is the rule of the thumb is that a probiotic where there's a combination of one or more lactobacillus species and one or more bifidobacterium or bifidobacterium lactis or lactobacillus reuteri species, then they have a very good efficacy. That probiotic combination is good. If you have one lactobacillus and you have one bifidobacterium species, then consider that as a good probiotic. Then interpretation in terms of mixed feeding. In mixed feeding, again, as bifidobacterium lactis and lactobacillus reuteri were associated with reduced risk of NEC in non-exclusive, that is in mixed feeding also. And if we try to find out in the mixed feeding which multi-genus probiotic was best, these three combinations were best. Lactobacillus rhamnosus and along with the other combination, again bifidobacterium with lactobacillus, and again bifidobacterium infantilis with lactobacillus acidophilus. So you could see that in the combination, one lactobacillus is there and one bifidobacterium is there. So these two produce a very good strong probiotic. In a nutshell, a single strain in human milk fed infant, bifidobacterium lactis and lactobacillus reuteri are the best. Again, in mixed fed infants also, bifidobacterium lactis and lactobacillus reuteri are best. In multi-genus human milk fed infants, these three combinations are good. Again, they have bifidobacterium as well as lactobacillus. These two should be there to say that the probiotic is good. And multi-genus strain and multi-genus strain also, these three are the ones which are good. Now, after summarizing this, there are certain limitations of this network analysis. The first important thing is that there is a network sparseness was a major issue. And the second important thing is that they did not include the extreme low birth weight infants or those who were having intrauterine growth retardation. So this was a major limitation of this drug. That's why this network meta-analysis was not used in order to establish the guidelines. This was the major drawback, and the next major drawback was there was a very high risk of bias in the 12 studies. Therefore, generalizability and clinical applicability of these results require further confirmation. Now, that is why this network meta-analysis, in the beginning I had told that this network meta-analysis, although we are discussing, but was not a very robust study. It cannot help us in establishing the guidelines. But I'm sure by after completing this, we are able to know that how do we read the Sukra plot, how do we read the league table, and how do we interpret the network meta-analysis. So the league table is very important. The Sukra plot is very important. League table helps us in assessing the head-to-head